Hello, everybody. This session is the Complex PCI 2021. The session title is featuring a training session and the clinical workshop step 3, stenting and optimization. I am Hong from Severance Cardiovascular Hospital. My co-moderator is Dr. Seth from India. We have several panelists, Kyung-Ha Park, Dr. Wagazuma, and Dr. Chan, Dr. Huang. In this session is have the full presentation. First, two presentation, I will introduce the first two topic, and the last two topic will be introduced, Dr. Seth. Okay, first topic is the over the troubled vessel, how to deliver the stent in the calcific and the tortuous lesion. This topic will be presented Dr. Lee from the United States. Please play his presentation.
Today I'll talk about over the troubled vessel, how to deliver stent in calcified or tortuous lesions. Let's talk about some of the techniques that we can use to facilitate stent delivery. First and foremost is optimizing the guide catheter. You want to ensure that it's coaxial. If you feel you need extra support, using a larger diameter guide catheter, 7 French or 8 French, is very handy. For the left coronary, an EBU or an XB guide catheter is that I find particularly helpful. For the right coronary artery, the Amplatz guide catheter can also facilitate stents and balloons. One of the game changers in interventional cardiology has been the introduction of the guide extension catheter, like the GuideLiner or GuideZilla. This is really extremely helpful to help facilitate very tortuous or angulated vessels which require a little extra support to deliver the stent. Long sheaths are also quite important. If you're going from the femoral artery, I find that a braided sheath to overcome, let's say, the aortic tortuosity or the iliac tortuosity is very helpful. If you're doing a case from the radial artery, a long radial sheath, let's say with a Terumo destination, 6 French, that's 60 centimeters in length, is also quite handy. For calcified lesions, plaque modification with atherectomy or intravascular lithotripsy is also quite vital to the success of the case. In terms of wires, initially traversing the lesion with, let's say, a workhorse wire, followed by exchanging out with the more supportive wire is an option. A buddy wire technique, and sometimes I've used as many as 3 wires to facilitate stent delivery, which provides more of a rail system, and a buddy balloon, and that is where you have a wire that acts as a buddy, but you could advance an expanded balloon, let's say a 2520 balloon, which gives you a little bit more girth and more support. Another technique is the balloon anchor technique, and especially if there is a previous stent in another vessel. For example, if you're trying to get a stent down the circumflex artery and the patient has a previous LAD stent, you could advance the balloon over the wire in the LAD, inflate the balloon in the LAD to provide more anchoring and stability. Breathing maneuvers can also facilitate the delivery of devices. Asking the patient to take a deep breath in will elongate the thorax, lower the diaphragm, and this should help you deliver a stent down to the desired location. And finally, vigorous coughing. So not just a mild cough, but just vigorous, as loud as the patient can. Coughing can increase intrathoracic pressure, which helps deliver the stent to its desired location. So when are guide catheters extenders indicated? So we talked about where a vessel is angulated or is tortuous. It can also be used with orbital or rotational atherectomy. It's also very useful in cases where there's chronic total occlusion, where it may be difficult to deliver your device. And guide catheter extenders can also be used with intravascular imaging. Let's talk about our first guide catheter extender is the GuideLiner. It's been around longer. I find this device a little bit more flexible. So for more angulated lesions, tortuous lesions, it's very helpful to get to the desired location. But once you overcome that tortuosity, from there you could deliver your stent to the lesion site. This is an example of a patient where we use the guide liner. You can see there is a severe focal stenosis. This was done at an outside hospital. There is a dog bone effect where the balloon would not completely profile. They aborted that procedure. The patient was then referred to us. If you look very carefully, there is a pseudoaneurysm or a contained rupture from the multiple balloon dilatations, but there still is a residual severe decalcified stenosis. Because of that pseudoaneurysm, it was difficult to advance the wire across the lesion. Eventually, we were able to cross the lesion. Orbital atherectomy was done to plaque modify the lesion. And here is your final angiographic result. The patient did very well. This is the guide liner being used to facilitate rotational atherectomy delivery. So you can see that there's a severe focal stenosis in the mid-RCA. In order to help facilitate delivery of the rotational atherectomy burr, a guide liner was advanced proximal to the lesion. The guide catheter was pulled back to allow for a more coaxial delivery. And here's your final angiographic result of the right coronary artery. There's a technique called the mother, daughter, granddaughter double guide liner technique, where basically you're using not only the 6 French guide liner, but also the 8 French guide liner. Here is a saphenous vein graft that is anastomosed to the obtuse marginal artery. There's a focal lesion at the bifurcation as well as in the distal circumflex. This operator initially advanced a 6 French guide liner to facilitate the traversing of the lesion with the wire. Once the wire was across the lesion, they advanced a 6 French guide liner and also advanced an 8 French guide liner. And here's the final angiographic result, which shows the lesion in the distal circumflex as well as the bifurcation of the circumflexa obtuse marginal have been stented. This is again another example where the mother, daughter, granddaughter technique was used. So they used a 6 French guide liner inside an 8 French guide liner. There was a chronic total occlusion, and here's your final angiographic result with the use of this technique. A version of the guide liner is the trap liner. This device has a balloon that you can inflate inside the guide catheter to provide more of an anchoring effect, so when you try to advance your device, the guide liner won't kick out. This can be quite useful. The other commonly used guide catheter extender is a Guidezilla. I find this device a little bit more pushable, it's a little bit more sturdy, and provides more support. This is an example of where the Guidezilla was used. You can see a very tortuous sigmoid-shaped right coronary artery. The Guidezilla was advanced to the right coronary artery, and here's your final angiographic result. It shows excellent results. Guidezilla can also be used when you have a lesion. It may be difficult to deliver. So by inflating a balloon, you can anchor the wire and advance your Guidezilla. Another technique is you could advance 2 wires through that Guidezilla, and this will help facilitate with the buddy wire technique to deliver the wire of the balloon in the stent. You can also perform rotational atherectomy through the Guidezilla. There are some complications associated with this technique. When you try too vigorously to advance a stent and you have to pull back out, the stent can be deformed, and when it's deformed, it can get snagged on the end of the Guidezilla, and this requires retrieval of the stent by just pulling the whole system out, which also includes a guide catheter. So complications include dissection. Anytime you're advancing the guide catheter extender down deep into the artery, there's always a risk for trauma and damage to the vessel, air embolism. That's why it's very important to be meticulous in terms of purging of the air, and stent deformation, which may lead to stent embolization. Here is a MOD database which shows some of the potential complications. We talked about the dissection. Perforation is relatively uncommon, but damage to the catheter or causing damage to the stent are well-recognized complications. So in summary, vessel tortuosity and calcification increase the degree of complexity of the PCI. I think one of the most important aspects of these interventions include having optimal guide catheter support. So it needs to be coaxial, using extra supportive guide catheters. The introduction of guide extension catheters are invaluable. And again, when you have a calcified lesion, plaque modification with atherectomy or with intravascular lithotripsy is very useful in delivering stents in severely calcified lesions. Thank you so much.
Very excellent presentation. Particularly in the first slide is a very classic and elegant summary. Let's move to the next topic. Next topic is the upfront tooth stenting in bifurcation disease, when and how. This topic will be presented by Dr. Hildik Smith from United Kingdom. Please play his presentation.
So, when to do two stents up front? I would say that the executive summary of my talk, in other words, the brief report, would be that when to do this? Honestly, almost never. And how to do it? Well, if you're going to do it, then use the technique that you've learned and practiced, whichever that technique is. As many people will know, I'm very much a proponent of the provisional approach. This is to treat bifurcations in a sequential and stepwise manner. It's a logical, planned, systematic approach, adding layers of complexity as necessary and stopping when you have a good result. You may end up with one stent or two. If you do end up with two stents, this is not a crossover or a bailout, as people like to say sometimes. It's the end result of a systematically planned provisional approach, which ends with two stents. So, for example, with the left main stem true bifurcation, you would stent the main vessel, then do proximal optimization, and then you'd ask yourselves, do we need to do anything more? If you do, then you would rewire the side branch, do a kiss, and then ask yourself, do we need to do anything more? And if you do, then you would stent the side branch. You'd kiss, potentially repot, and look at your final result and ask yourself again, do we need to do any more? If so, perhaps tap, T, culotte. So the risks with complex approaches are that the more steps you involve in a process, whatever that process is, in medicine, outside medicine, the more chance there is of something going wrong. So for an optimally done bifurcation case, will the risk be the same for one stent or a two stent technique? Or with a badly done case, is there more opportunity for mayhem with the more complex approach? If, for example, I do 300 cases per year, that would make me a high volume operator in Europe, and 15 cases of bifurcation, 15%, sorry, and if 10% are for sort of big bifurcations, then that would still mean that I only did about 4 cases per year of bifurcations which ended up with 2 stents. So we have to remember that there's nothing more likely to go wrong than a complicated bifurcation strategy undertaken as something of a novelty. If you look at the analysis of what is admittedly some old study now, BBC One and Nordic, you can see that even in the patients here highlighted who had a side branch diameter greater than 2.75 and a lesion length greater than 5 millimeters, the simple approach was still preferred in terms of outcomes. These are patients in whom many operators would consider 2 stents to be required. So, of course, we looked at this in more detail with the European Bifurcation 2 stent study, large caliber true bifurcations, And actually at 1 year, we saw no difference between the two strategies. And perhaps most interestingly, only 1 in 6 of the patients who had this kind of side branch anatomy actually required a second stent. So the recommendation could be to use the provisional approach for the following reasons. You can always put in a second stent if you deem it necessary. We went on from there, as many of you will know, to do the EBC main study, which is recently published. And the background is that there's been a lack of studies showing systematic benefit for two-stent strategies, apart from all the DK crush studies. And actually, the longest term follow-up that we have of two-stent dedicated dual implantation shows an adverse effect from about 3 years on for the two-stent strategy. And that's something that we have to bear in mind, particularly when reporting 1-year outcomes. So the setup of the EBC main was as shown here, and we recruited roughly 460 patients to this study. The primary endpoint was a 1-year endpoint, although we will report 3- and 5-year outcomes, and it showed no difference between the two groups, stepwise provisional on the one hand versus systematic dual on the other. The individual secondary endpoint components similarly did not show any significant differences, perhaps a numerical disadvantage in the systematic dual stent group. Here are those results shown graphically. If you look at the procedural flow, again, it's interesting to note that particularly with regard to stenting of the side vessel, only 1 in 5 of these vessels actually needed a second stent in the stepwise provisional approach, even though all the operators were happy to randomize the patient and were therefore happy to put in 2 stents if that's how the randomization had gone. So this is quite sobering. In fact, only 1 in 5 of them needed that second stent on the provisional approach, and outcomes were the same at 1 year. So why would you do 2 stents up front? Well, of course, there's the huge volume of excellent DK crush data to absorb. Multiple studies looking at this in large volume. And their studies have shown outcomes which are better than provisional and better, for example, than mini-culotte. So why the difference between these studies? I think at its simplest, you could say that in the Chinese studies, there's been more extensive disease, in the side branch in particular, longer disease, a higher syntax score on average, and importantly, I think more learning and understanding and belief in the DK crush technique, and therefore a philosophy bias in favor of the DK crush. Whereas the opposite is true in Europe, less extensive disease, slightly lower syntax scores, more belief in the provisional approach, and again, a philosophy bias, but in the opposite direction. So for complex left main bifurcation in particular, you can use provisional or systematic dual techniques. Provisional resulting in 2 stents is equally applicable. And really the main thing is that if you're going to do complicated left main stent bifurcation, stent implantation, learn a technique and apply it rigorously and carefully and observe and obey its rules. The technique itself is less important than its application. And at this point, I would say that I think the guidelines have been unhelpful in Europe. Specifically mentioning a particular technique is really not helpful because it encourages some people to consider doing a DK crush, even though that's not what they do. They've never really done it, but they think, oh, I better do a DK crush because it's left main. This is not the way things should be promoted, in my view. So finally, to come back to the question that I was actually asked at the start of the talk, and that is when to do 2 stents up front. And I would say that there are only 2 situations where this is necessary. and should be considered. And the first is this important situation, which is infrequent, but is important to note when you come across it. Like most rules, they're there to be broken occasionally, and this is one situation where you break the rule. And that is that in the drawing I've done here, I've tried to indicate a retroflexed large first diagonal with heavy disease in the LAD, rendering this very difficult to access. So once you've actually successfully accessed it with the wire, the last thing you want to do in this setting is jail it and make it difficult to access again. You want to secure it. So you would, in this setting, stent with your chosen technique, be it culotte, this is suitable for mini culotte, crush, tap, etc., etc. There are different techniques. Tap would turn into culotte, into mini crush in this setting. So that's one situation where the side vessel is very important, mustn't be lost, and is very hard to wire. The second setting is that when you're already certain that the side vessel will definitely require a stent, then you choose your technique of choice. And for me, that would still be provisional, and I would then stent the side branch as part of that provisional technique. Largely because I don't want to prejudge the issue, and quite often you actually find, oh, I don't need that second stent after all. But equally, if you decide up front you absolutely need a second stent in the side vessel, then use your technique of choice. This may be DK crush, it may be mini culotte. It doesn't matter. What matters more is that you use a technique that you've learned and one that you've practiced. It isn't really plausible that a perfectly done mini culotte and a perfectly done mini DK crush have materially different clinical outcomes. Thank you very much.
Thank you very much, David. That was an elegant presentation. Clearly, you were very convincing in your and you're very persuasive. I think we should go on to the next stop. That is to kiss or not to kiss. That's the question. Optimization of stenting and bifurcation PCI by Dr. Chiefo. So we'll have her lecture.
I'm Ali De Cheffo from Raffaele Scientific Institute, and I'm going to talk regarding the usage of kissing balloon inflation and in general optimization of provisional stenting. In the decision making of the technique to be used, it is detrimental the importance of the side branch. In this study that was published last year in Neurointervention, it was nicely demonstrated how the size, number, and dominance of the circumflex was going to impact on the percent of fractional myocardial mass supplied by diagonals. So, if you have one diagonal branch in a non-dominant circumflex, 17.6% is the territory that is going to be supplied by that diagonal. Indeed, if you have one diagonal and a dominant circumflex, that diagonal will have 6.7% of territory supplied. And this is a clear demonstration how the size and the size of that diagonal and the presence or not of a dominant circumflex is going to impact also in our decision making. We are going to discuss about kissing balloon inflation and proximal optimization. Both techniques are intended to limit the risk of side branch compromise through two mechanisms: spiky carina shift and longitudinal plug shift from proximal main vessel. The distal main branch is going to be the stent on the main branch is going to be sized according to the distal reference. In this case, you are not going to have a carina shift, but however, you need to perform a proximal optimization in order to be sure that the proximal segment is going to be fully dilated. Key points for is where is placed the stent, because the stent has to be placed proximally enough to allow to have balloon inflated without touching the bifurcation. POT is to be performed before the wire exchange. You have to know your non-compliant balloon specific. You have to size the POT according to the proximal reference, and the distal marker has to be at the carina level. POT has been demonstrated to be correlated with a higher stent volume as compared with non-POT, and POT has been demonstrated to decrease the fractional flow reserve when performed. COBIS-2 sub-analysis that took into account only patients with a side branch more than 2.5, the performance of POT was going to be correlated with a lower occurrence of MACE, mainly driven by TLR, as compared with non-POT. This is the e-Ultimaster registry, more than 1000 bifurcation. Again, POT demonstrated to be correlated with lower occurrence of MACE as compared with non-POT. And this was not only seen in the target lesion vascularization or target vessel failure, but also in the lower occurrence of stent thrombosis. Provisional side branch standalone POT is the Nordic 3 Spirit, which are the potential benefit of side branch opening is avoiding periprocedural occlusion and non-coave MI, relief of angina, and keep access for future interventions. Side branch fenestration, however, can have as a consequence stent distortion and need for kissing balloon inflation. There is no doubt about the importance of kissing balloon inflation in two-stent strategy. In the Nordic 3, indeed, it was evaluated kissing balloon inflation versus non-kissing balloon inflation in provisional stenting, so in stepwise approach, with the stenting first in the main branch and then re-evaluate after that. And in that case, there was no difference in occurrence of major adverse cardiac event, performing or not final kissing balloon inflation. However, when there was done a sub-analysis taking into account only true bifurcation, in true bifurcation, indeed, there was an impact of final kissing balloon inflation. In this table are reported different studies evaluated kissing versus not kissing. No significant difference. The only study that showed a trend with an amelioration of kissing balloon inflation in the outcomes was again a COBIS-2 sub-analysis. This is indeed a sub-analysis from the RAIN registry. It was evaluating bifurcation in the left main, and in this specific sub-analysis there was no impact of final kissing balloon inflation versus non-final kissing balloon inflation in the occurrence of major adverse cardiac event or stent thrombosis. Optimized kissing balloon inflation, you have to have a distal cell wiring, non-compliant balloon size to the distal reference, and a minimal overlap. Another possibility is to have an asymmetrical kissing balloon inflation. In this case, you are going to have less bottleneck effect. And then, after the kissing balloon inflation, it is indicated and suggested to have a final POT in order to eliminate the final ellipticity. POT, side, and POT can be suggested as an alternative. In conclusion, bifurcation stenting should follow anatomy. We have seen the importance of side branch to dictate the kind of technique that you are going to use. POT is useful in all bifurcation as distal vessel sizing limits carina shift. Kissing balloon inflation may be useful after single stenting, necessary after double stenting, but it could be deleterious in non-true bifurcation. Benchmark and virtual evaluation suggests a benefit from new kissing balloon technique, need for final POT, possible competition of POT, side, and POT versus POT, kiss, and POT, However, clinical validation of optimized kissing balloon inflation is still missing. Thanks for your attention.
Thank you very much, Dr. Elodie Kifo. That was tremendous, and I think we're really going to have a lot of discussion on bifurcation during the panel discussion. I think we will now proceed to our last talk before the panel discussion, and that is of under pressure optimal post-dilatation strategy by Professor Ahn from the Asan Medical Center, Republic of Korea. Dr. Ahn, over to you, please.
Thank you for a very kind introduction. My topic is optimal post-dilatation strategy. Actually, PCI procedure is very simple. After wiring, pre-lesion modification, stent implantation, post-dilatation, very straightforward. But actually, I was very surprised to see this paper, and from the experience of BVS implantation, each step, it looks very simple, but each step, if we did not perform adequately, is associated with the worst clinical outcome. Of those, even though the BVS implantation, only 5% of patients achieved optimal pre-dilatation, sizing, and post-dilatation. It was very surprising. In addition, the post-dilatation, adequate post-dilatation is associated with the late event. After 1 year, adequate post-dilatation is associated with a significantly lower event rate, even in the PRS. So we performed a similar analysis in our DS registry, IDSF registry. Patient number is 9,000 patients. All patients have complex coronary anatomy, long lesion, bifurcation, left main, calcified lesion, instant restenosis region. Pre-dilatation performed 90%, sizing by IVUS performed 54%, post-dilatation 58%. All of three compounds achieved in only 1/3 of patients. This patient defined as IPSP population. Compared with the no IPSP population show that the low risk of primary endpoint death, MI, repeat intervention, and low risk of cardiac death, and low target vessel MI. There is no difference because of very low incidence, and target vessel revascularization lower in patient with IPSP. Of those three components, post-dilatation is the significant predictor for primary outcomes. Only pre-dilatation, stent sizing by IVUS is not independently associated with outcomes. More interesting part is this. We made a separate scenario, pre-dilatation, IVUS, post-dilatation. Look at no pre-dilatation, no IVUS, but post-dilatation. Stent diameter is 3.0. Post-stent balloon is only 3.1. Less aggressive post-dilatation strategy. Another case is the same. Look at no IVUS, no imaging guidance, post-dilatation. The post-dilatation balloon size is very small. But look at IVUS and post-dilatation, IVUS and post-dilatation. Post-dilatation size is significantly larger than stent diameters. So associated with the lower risk of primary endpoint. This is very important. Post-dilatation itself is not important. IVUS guidance may affect the benefit of the post-dilatation. Even though post-dilatation is not frequently performed in the real-world registry. SCAR registry, 93,000 patients, only 32 patients receive post-dilatation after stent implantation. Our registry, 58%. So what is your ideal post-dilatation strategy? Stent balloon, high pressure balloon, what pressure would be optimal? How to use the imaging guidance? What is the target for post-dilatation? First, this is a very famous graph. Stent balloon is not enough. Even though stent is well expanded angiographically. When we evaluated IVUS, DS achieved only 75% predicted minimal stent diameters and 66% of predicted minimal stent area. So even though angiographically well expanded stent by using stent balloon, minimal stent area is less than 34%. When you then less than 34% than when you expected after stenting. So I think post additional high pressure balloon is important. The wall pressure, there is not much data. I found one registry data from SCAR registry. They divided the patient according to the high pressure post dilatation balloon size, 15, 16, 19, 20, more than 22. So stent thrombosis, the risk of stent thrombosis and restenosis is reduced according to the post-dilatation pressure is increasing. But very high, the post-dilatation balloon pressure is a little bit increasing the risk of stent thrombosis and restenosis. Actually, this is registry data. There is some limitation, but we can say that at least more than 20 atmosphere would be an optimal optimal pressure for the post-dilatation balloon pressure. So the post-dilatation itself is why important. The Antonio Colombo nicely demonstrated that 26 years ago, the look at after stent implantation, there is just some Marapos area on the expanded stent. But based on the IVUS finding, he applied the post-dilatation. He made well opposed the stent position, so he can decrease the he could decrease the stent thrombosis risk from the 3 to 4% to the 1.6% next 6 months. This is the very first report to why we have to do post-dilatation based on the IVUS guidance. The IVUS experience study, ultimate study, nicely demonstrated that the benefit of IVUS guidance. More importantly, I think IVUS experience studies contained very interesting findings or information about the post-dilatation. In this randomized trial, in IVUS guided groups, post-dilatation was performed in the 76%. CAG guided groups only 57%. So after IVUS evaluation, the more frequent post-dilatation appliance would be the one benefit of IVUS guidance is associated with the better clinical outcomes. Another important information from this study is IVUS group. In the IVUS group, Dr. Hong divided into two groups, meeting the criteria, IVUS optimal criteria, and not meet IVUS criteria. He defined the IVUS criteria for stent optimization after PCI was defined as a minimum lumen cross-sectional area larger than lumen cross-sectional area at the distal reference segment. Even though IVUS was performed, some groups did not meet the IVUS criteria. It is associated with a higher event rate. So I summarized the graph. So CAG guided groups, 1 year primary endpoint is 5.8%. IVUS guided group, meeting the IVUS criteria only 1.5%, but not meeting IVUS criteria 4.6%. So why we do IVUS? Why we do post-dilatation? We have to decrease the clinical event. So we have to do IVUS. Performing IVUS itself is not enough, because knowing if we want to change our something, the knowing is not enough. We have to do more based on our knowing. So when you see the IVUS, we have to find the suboptimal result. We have to apply the post-dilatation adequately. What is adequate post-dilatation? I think any kind of IVUS criteria or any kind of criteria, we have to meet a certain criteria or minimal stent area. Minimal stent area and avoid the under-expansion is most important factor to guarantee the favorable long-term outcomes. This is Dr. Hong's data. Non-left main stent, for the non-left main stenting, we have to achieve the minimal stent cross-sectional area more than 5.5, associated with the lower risk of in-stent restenosis. Another consideration is pre-lesion modification. So if we do not make a good lesion modification, so once we implanted the stent like this, stent under expansion here, the post-stent implantation, additional very high pressure overdilatation sometimes cannot achieve the sufficient stent cross-sectional area. So for optimal post-stent strategy, pre-lesion modification is very important and prerequisite. This is my final slide. What is optimal post-dilatation? I think optimal post-dilatation strategy can be defined as the imaging-guided post-dilatation strategy to achieve the sufficient minimal stent area at any criteria, regardless of balloon type or inflation pressure. In addition, for optimal post-dilatation, pre-lesion modification is the prerequisite. Thank you for your attention.
Thank you very much, Professor Han. I mean, that was tremendous. You made, you told the science, philosophy, but the evidence for post-dilatation. I think it's something which everyone should practice. And then this is now open for discussion. And maybe I'll just start off with the discussion to you, Professor Han. You've emphasized image-guided strategies. Do you believe that the image-guided strategies are only for complex lesions, say heavily calcified, say bifurcation, left main, or are you suggesting that image guidance should be for all stentings, for all PCIs?
Yeah, thank you for very, very important questions. Actually, I'm addicted to the imaging-guided PCI, so I always use IVUS in any cases, even in simple cases. But to prove the benefit of IVUS guidance or IVUS-guided post-dilatation strategy in simple case, almost impossible. We have to gather more than several thousand patients. So the scientifically, no. But theoretically, I'm yes. So practically, I'm doing IVUS guidance even in simple cases.
Over to you, to others. I think this is great discussion.
Mm-hmm. In the current evidence, the simple lesion is that actually there is no difference of the long-term clinical outcome between the imaging guided versus the angio guidance. The reason why the current device and the pharmacological treatment is more advanced. Therefore, the evidence for the favoring of the imaging guided PCI is a complex lesion. But you know that we need some exercise or practice with the simple lesion, with based on the experience of in simple lesion, and then extend and their experience to the more complex lesion. Without the experience of the simple lesion imaging guided PCI, just apply in the complex lesion. Actually, it is not a real meaning of the imaging guided PCI. Dr. An, could you share your slide, one of the interesting slide, the 8 group, imaging based IPSP technique in your slide 8 group. That I think is a very important the message to the leaders, the reason why every interventionist believe that still what is the truth? Bigger is better. That is that when you look at that in the group number 4, only post-dilation. The interventionist who does not use the imaging, they did post-dilation. They think that their angiographic result is excellent. But look at that, the MLD, even though post-dilation 3.1, but the number group 6, that the group 7 and 8 using the IBIS guided, the MLD is quite larger compared to the group 4. It is a very important meaning. What I mean is that the interventionist who does not use the imaging, they did the post-dilation, but actually they do not achieve a larger, greater MLD. We have to be emphasized to use the imaging in every DCI cases.
I just want to slightly rephrase what you've said. And I would say that, yes, every interventional cardiologist during the training stages must use imaging for almost all cases so that they get a sense of the vessel size, the disparity of vessel size at angiography versus intravascular ultrasound, which is how they will translate into practice, at least for simple lesions, where I know that if I see a 3 millimeter vessel angiographically, I will finally go anyway with a 3.25 or a 3.5 balloon at moderately high pressures to get my final results. So that would be in simpler lesions, but in complex lesions, not just for optimization, but for safety, I would use intravascular imaging, because when I go in heavily calcified lesions to ultra high pressures, I also want safety, not just optimization, but safety and appropriate sizing of my balloons. So that's my perception as a whole of the last 30 years for imaging. And that's why we don't see so much of imaging happening for simpler lesions. Though I believe that it must be absolute must during training to an initial stages of every interventional cardiologist practice.
I'm Dr. Park from South Korea. All of us think that the image-guided post-dilation in simple and complex regions shows good data. However, practically, in daily practice, the image study is not always available in some cases. So my question is to Dr. An, without the image-guided routine post-dilation will be not effective both in simple and complex region if there is no residual stenosis in the stent. What do you do?
Yes, these are very important questions. IVUS catheter is very expensive, so because of cost and time, sometimes we did not perform the IVUS guidance. But if I have confidence about the vessel size, I can do aggressive post-dilatation. But if I don't have any confidence about vessel size, I cannot apply the effective post-dilatation. So, frankly speaking, without IVUS guidance, I cannot say the post-dilatation is effective. But rather, the tool, the trick is you can measure the QCA instead of IVUS. So based on our BRS experience, the QCA is much better than the IVUS evaluation of coronary angiogram. So if you measure the QCA, minimal lumen diameter or minimal stent diameter plus 0.5 bigger balloon size, it would be effective in case of IVUS is not available.
I think we should move on to the other topics, isn't it? I mean, this was a great discussion on post-dilatation. I just wanted to ask Dr. Lee and then other people, in the panel. Great cases about very difficult and tortuous anatomy. Can you just guide everyone as to the size of burr which goes through the guide liner, the 6 French guide liner and the 7 French guide liner, and the precautions to take while doing that? I think that's an important aspect of practical discussion.
Yeah, first of all, Dr. Seth, it's good to see you. I predominantly use orbital atherectomy. So the beauty of orbital atherectomy compared to rotational atherectomy is that there's only one crown, 1.25. So 1.25, a high speed gets you about 175. So you could actually do a case through a 6 French and get you what amounts to be similar to a 175 burr. But you don't need a 7 French or 8 French guide catheter. Now, to answer your question, 6 French guide liner, 1.25, 1.5 should be fine, but anything higher than that, you need to use the 8 French guide liner. But that's why I use the orbital atherectomy, because you can do everything through the 6 French radially.
Absolutely, and I was just going to say that the 1.5 burr does not enter through the entry port of the 6 French and has even a problem through a 7 French guide liner. So every time I end up with a 1.25 millimeter burr in 7 and 6 French guide liners. And that's sort of the practical aspects that I was talking about. Any role of wiggle wire? Who uses wiggle wire around? We don't certainly have it with us, but that's one of the things which Americans use quite a lot. Michael, what's your comments on that?
Yeah, I haven't used a wiggle wire in over 16 years since I've been in practice.
Okay.
It's been used when I was in training from interventional fellowship, but I don't think we even have it on the wall. And there's always other tricks and tips that you can do to traverse, let's say, a side branch to get you off the side strut, etc. Sometimes just twisting balloons on a wire, or getting a stiffer wire, etc. Or again, I like my technique of having patients cough. I'm not talking about a really, really intrathoracic pressure elevation or deep breath in to elongate the aorta. I find those techniques quite helpful.
For the RCA and the circumflex, they seem to be very good for the RCAs and circumflex bends and curves.
Yeah.
I think it's worth stating out here, especially because a lot of fellows are going to listen to this, is that when you have 2 wires down and you've got a very supportive wire and then you have a medium support or a lesser supportive wire, it's worth trying both wires to get a stent down, because the stent may not go down the stiffer or the more supportive wire, because that's going to direct it against the calcified bends, and it may still go down the lesser supportive wire or the more flexible wire. Any comments around the panel for that?
Yeah. I mean, I was just going to say, you would think that the wire that was initially there, you try to track through that. But, let's say you get a BMW as your second wire, just perhaps a little bit of geometry change gets you through, and you just never know until you try. But I'll actually try times where I've tried 3 buddy wires. That's not commonly done, but just extra little bit about support, and then your breathing techniques, your coughing techniques, just kind of going back and forth. Or also, when you have 2 wires down, actually, when you pull back your buddy wires, your balloon or stent actually goes forward. So that kind of gives you Laplace's law: for every action, there's an opposite equal reaction. So that helps as well.
I don't think David Hildick Smith has joined in, but I think I'd rather pass it on to Alan Chan and my colleague Park and Wakatsuma. And I think my discussions around the 2 stent strategies are very important. And if we have time for that, I would actually say, Alan and Dr. Wakatsuma, are you a provisional strategy person, or do you rely on the definition criteria for deciding upfront 2 stent strategy in a fair proportion of your patients? Please, I mean, that's an important aspect of discussion, to take a midline rather than one or the other.
Yes, yes, I'm Alan from Hong Kong. Yes, so actually, basically, I totally agree what the speakers talk about, the provisional versus the 2 stent techniques. personally, of course, there are lots of bias. All of us have bias. So, and I think we are from Southeast Asia. We agree. We tend to have a belief to have a bias on two-stent techniques, including me. And of course, European, American, and US, they all have bias towards the provisional. But of course, it all depends on the case-by-case base, right? Basically, if you want to incorporate everything together, what we learned today, so we have topic about two-stent, one-stent, how to optimize it, imaging guide. In case we incorporate everything together, so a decent, meticulous, IFAS imaging guided approach to any kinds of bifurcation is essential. So you incorporate all the IFAS findings, anatomies, and then choose the best methods, either a provisional in case the anatomy favors, or you two-stent. Of course, we also have some bias towards DK cross. I don't know how about the rest of the panelists or the moderator speakers, right? Apparently, from the large volume experience with experienced operators, they can achieve a potential better result. I don't know how about the rest of the panelists have the belief.
Yes, yourself, definition criteria as the criteria of choice for deciding between the two strategies.
Actually, personally, I do not hesitate to perform complex stenting. I think I totally agree with the previous panelists. The difference between the DK crush study and the European bifurcation study, it's a quite different patient population. Chinese and also Japanese patients tend to hate to select bypass surgery. So we need to treat a very complex, very tortuous cross-firectomy bifurcation. If we need to treat such kind of patient for the single stenting, sometimes the second stent delivery is quite difficult. So I do not hesitate to perform. Personally, I prefer to perform mini crush.
Right. So you have a lower threshold, say, for two-stent strategies.
Yes.
And you feel that upfront two-stent strategies can make life simpler and less complicated rather than a bailout strategy. I think that's the philosophy that most of us in Asia have, that we understand the benefits of a single stent strategy, but we don't stay away from two stents to the same extent as the Europeans try and do, because the layered strategy, I do believe, has certain flaws when you come to highly complex bifurcation lesions.
What about Michael Lee? What is the opinion for the upfront two-stent technique or provisional stent technique?
I like the upfront two-stent technique. The reason why is the following. I've had times where I did a provisional and the side branch was compromised.
Correct.
And it was quite difficult to get the wire back down. It's not common, but it has happened. So let's say we get the wire down, and there's been times, let's say the circumflex when we're doing left main is quite at a steep angle. So because you have a stent there, and to try to get a stent around into the circumflex with the stent already there, I've had issues with that. So, if you go up front as an A priority, you can do two stents. Actually, it goes very fine. But again, sometimes where that circumflex pinches, or if it pinches and there's too flow, and the patient's ischemic, chest pain, hemodynamic compromise, and becomes an emergent bailout situation, then you don't do things well. So I think if you have a lot of experience, a crush technique, whatnot, very straightforward. So I like the two-stent approach.
Thank you very much. I think that's been a great discussion. I think we've had a lot of learnings. The learnings from how to cross wire through difficult, tortuous, calcified anatomy, how to get our stents there. The discussion on bifurcation has been immense. Post-dilation, a very important aspect of optimal stenting. And we're in the realms of stent optimization. The stent designs have improved, the stent thickness has decreased, our results from third generation stents have improved. And finally, the techniques also have to evolve, therefore, to give the best results to our patients. So this has been a great discussion, and I certainly think that every speaker has contributed immensely to making us do better and safer angioplasties and give the best to our patients. So that with those words, thank you very much. Great session. Thank you all the panelists for being a part of this great meeting.
Excellent.
Thank you.